People say that necessity is the mother of invention, isn't it? What is the axiom? What is the dictum? People say that necessity is the mother of invention. I do not agree with this one. I do not agree with this sentence. My dialogue is curiosity is the mother of invention. Whether it is advantageous or disadvantageous, whether it can throw you into a pit dug by yourself, or it can give you a platform to do something for the biological world, for the human being or the animal, whatever. All right, for yourself or for others. The basic thing is your curiosity. Because we learn by, remember, we learn by curiosity and we adopt by wisdom. We learn by our curiosity and adopt by wisdom. So, in taking follow-up, pursuit of our curiosity, sometimes we do some mistakes, isn't it? And definitely we, the human being, always learn something out of that. It is not and never useless. Alright? Why I am telling this? Now, as I have asked you, can any boy describe testicular pain? Suppose you have gone to an emergency out of your testicular pain. Somebody has kicked into your ball or during playing, alright, but you don't want to mention the site or some word that represents scrotum or testis, right? That is, my ball is paining, alright, my sac is paining, nothing like that. You just want to inform the female doctor, the nursing staff that there is a severe acute pain in your testes. Human describe without uttering a word indicating your sac or your ball. What is the nature of pain? And what is the term for pain in the testes? Can anybody tell? Remember, this is neither a quality or gripping pain, nor a throbbing pain, right? Nor a tearing pain, nor a stabbing pain, nor a crushing pain, nor a gripping pain, right? Neither tearing, nor crushing, nor penetrating or stabbing, neither gripping or colicky, nor a not a expansion or throbbing pain. Then what is the nature of the pain and what is the testicular pain is called? Remember, the biological term is orchialgia, or better orchidalgia. Orchidalgia, O-R-C-H-I, orchidalgia. In Sanskrit, arca means sun. So it is a tissue out of the solar energy in our body, right? So it is orchialgia or orchidalgia, right? Now what is the nature of the pain? The pain is, if severe, it is a severe acute asphyxiating pain. It is a severe acute asphyxiating deep-seated pain. Alright, this is a deep-seated pain. Though the trauma is at your sac, but you cannot diagnose that the pain is there. Alright, it is near around the umbilicus and even higher. Alright, you cannot localize. And it will, what it will cause, you have seen perhaps when you observe contact sports like football, right? Alright, somebody after trauma to his sac, what happens? He just closes his mouth, nose. Yes or no? This is the expression of your severe acute asphyxiating pain, that is the orchidalgia. Got my point? Alright, remember this thing. Of course, as the segment, why it is around the umbilicus? Because the segmental supply of the testis is T10. Sympathetic supply is T10. Alright, I will ask you. This part I have described earlier, didn't complete. Alright, as you see, this is the processus vaginalis, remnant of processus vaginalis. This is the Tunica Vaginalis. Alright, that is the vaginal sac over the testis. That is the vaginal sac. That is the remnant of processus vaginalis. Okay? Alright. Now deep to it, there is a thick fibrous layer, just like the spleen. As it enters, the fibrous capsule enters the fibroelastic tissue covering the spleen, enters through the hilum and gives out ramifications like septa, and from there multiple trabeculae come out and gives spleen as a lobular structure, isn't it? Similarly, this mediastinum testis gives out from its anterior margin, alright, multiple septa that divide the testis into around 200 to 300 lobes, alright. Each of the lobe containing 1 to 3 seminiferous tubules, right. Now, you can see that the blood vessels entering, they come through this fibrous septa, alright, and ramify according to this fibrous septa, alright. They come like this. Remember, the blood vessels, all the blood vessels, both artery and vein, enters the testis around through its posterior border. It has upper pole directed upward and laterally, lower pole directed below and medially, a lateral surface, a medial surface, a posterior border, one anterior border, right? In the posterior border, we can identify above there is the epididymis, and the descending part, that is the body of the head of the testis, is epididymis, and then there is the body and tail of the epididymis, from where the vas deferens starts, and the lower pole is attached to this lower part of the tail and vas deferens by a fibrous band, right? This is a gross structure. Now, if you want to see a testicular section, remember, if testicular histology comes, we will always draw it with more magenta color. Don't try to show anything. Alright, like nucleus, Golgi apparatus, mitochondria, blood vessels. You can draw 1 or 2 blood vessels only, not more than that. Don't do anything. Alright, just put some close this kind of structure. We will make it just like this. Got my point? Just keep narrow the space, some elongated space like this in between. Alright. Make some gap so that some elongated structure can be shown. This much is enough for testicular histology. Alright, because in hematoxylin eosine state, the different structures cannot be identified, and that's why the particular structure that represents the testis, that is the seminiferous tubule. Alright. Better say the Sertoli cells and the Leydig cells. Sertoli cells are within the seminiferous tubule. Right? From the basement membrane of seminiferous tubule, this is the seminiferous tubule. This is the basement membrane, right? This is the basement membrane, close to which lies the large polyhedral cells, that is the spermatogeneric cells, that is spermatogonia A and B, right? Some are dark, some are light. Then comes the primary spermatocyte, which are small polyhedral cells, right? Then comes the secondary spermatocyte, which are again small cuboidal cells. Then comes the spermatid series. All right. Then comes the spermatozoa. Some are immature and some are mature. The mature one faces the lumen with their head towards the lumen, right? The immature one is deep within the crevices, the folds of Sertoli cells. These are the Sertoli cells. And in between the tubules, there are Leydig cells. Remember, the Leydig means leader. That is, testosterone is produced by the Leydig cells, right? And Sertoli cells produces some estrogen, inhibin, etc. All right. Leydig means leader, so it elaborates testosterone, right? You will not forget this. So that's why these cells are for steroidogenesis. These cells are laden with cholesterol, fat, phosphate, and as well as ascorbic acid. As well as ascorbic acid for steroidogenesis. But in normal histology, we are unable to delineate. In 80 stain, we are unable to delineate either the Sertoli cells or the Leydig cells. Sertoli cells can be identified because of their large size and abundant amount of cytoplasm. Got my point? Abundant amount of cytoplasm, and there are cytoplasmic processes around these cells. These are cytoplasmic processes of the cell membrane, which can be seen, but cannot be definitely identified as Sertoli cells. And for that, we use a immunohistochemical stain. Immunohistochemical stain, that is antibody to inhibin hormone. That is antibody to inhibin hormone. This much is enough. That stains the Sertoli and Leydig cells in brown coloration. This much, if you can write, if histology of testis comes, this much will be enough. Inhibin, antibody to inhibin, acting as immunohistochemical stain the Sertoli cells and the Leydig cells as brown in color. All right, not the other cell. Right? Now, as you can see, these blood vessels are lining the inner part of this tunica albuginea, as well as around this 1 to 3 seminiferous tubules in each lobes, right? From this tubule, there are some straight tubules that goes towards that crosses the mediastinum testis, right? These are known as straight tubules. Around 30 straight tubules are there. Thereafter, towards the apex, it forms a network that is known as the reti testis, right? These reti testis again give rise to reti testis is around 12 to 15 veins. Then, at the upper pole of the testis, these coalesce to form 5, 7 or 10 large headed tubules, which are called efferent tubules. That makes the head of the epididymis. So, efferent tubule makes the head of the epididymis. Their lumen again coalesce to form the body and tail of the epididymis, and continuation of which is the vas deferens. Right? Continuation of which is the vas deferens. Now, let us talk about what could be the arterial supply is what? That is a gonadal artery at the level of L3 from there is a lateral branch or splenic branch from the abdominal aorta. You will read these branches of the abdominal aorta, you will read. Alright. What other? There is a communication to the testicular artery and the artery to the trimester. There is a communication in between the testicular artery and artery to the trimester, as well as artery to the vas. From where artery to the vas comes? Artery to the vas comes from superior or inferior vesical artery branch of obliterated umbilical artery. You have heard the term obliterated umbilical artery? Right, from obliterated umbilical artery, the part remains patent. Either the superior vesical artery or the inferior vesical artery supplies the testis. So, artery to vas and artery to trimester. Artery to vas and artery to trimester. Trimester comes from inferior epigastric artery. Artery to trimester comes from inferior epigastric artery. Right? Right now, I need to rehear what are the contents of spermatic cord. What are the contents of spermatic cord? Number one, vas deferens. Right? Then the artery to vas, artery to trimester, nerve to trimester, testicular sympathetic plexus, testicular pampiniform plexus, the extraperitoneal fat. All total 8 structures are there in the spermatic cord. Right? Remember, the artery to trimester comes from inferior epigastric artery, artery to vas comes from superior or inferior vesical artery coming from obliterated umbilical artery. Right? Obliterated umbilical artery is again a branch of internal iliac artery. Right? It is coming from internal iliac artery. Right? So, these are the structures you need to know. Now, if you want to trace where does this nerve supply is treated, nerve supply is treated as it is treated. Spinal segment, that is the lateral column of T10, that is the sympathetic supply. Alright, there is not that much parasympathetic supply. And as the segmental supply is treated, you can well understand that any pain associated with the testis can be referred to the structures that are also supplied by the testis, that is the appendage, alright, around umbilicus, all these structures that can be experienced and referred pain. That's why I have described the testicular pain is not a very much well localized pain. Alright, it is deep seated and vaguely localized. Got my point? Now, artery supply and the vessels enter the testis through a posterior border. This should be remembered. Alright. Now, if you want to see the course of if you do not know the course of the vas deferens, you do not know anything about anatomy. Alright. Its length is a tube for carrying the seed. Alright. For carrying the seed. It starts from the lower pole of the testis. Alright. reaches to the upper pole, and from the upper pole it enters the superficial inguinal ring, then to the deep inguinal ring, where it crosses basically the inferior epigastric artery. After passing through the deep ring, the inferior epigastric is like this. Alright, this is inferior epigastric artery. So vas deferens is at first lateral to it, then posterior to it. Right? Then it is running medially, then downwards and medially. Let me draw a picture, you will understand the course of the vas deferens. Vas deferens is very important. I do not talk much about phimosis or varicocele or something, because these are the surgery of quack, not for us. Alright, give this to the quack, do them, let them do. Can you recall this diagram? Can you recall this diagram? Somebody has attempted the question on obturator now, but they give a figure that is, I say it is for the descriptive purpose, it is all right. I can give them some mark, but this is the original diagram you have to draw for the relation of obturator now, right? So this is the inner aspect of the iliac crest, iliac bone, all right. This is the iliacus, and by the side the psoas major is coming down, all right. And this is the iliopsoas tendon, all right. And medial to it, the psoas major fossa is here, medial here by the obturator nerve, right. This obturator nerve is going to the obturator canal, not obturator foramen, all right. This is the obturator canal. Rest is blocked by the obturator membrane, right. There it divides into anterior and posterior division, right? And similarly, there are obturator artery and obturator vein. And above all this structure lies the obliterated umbilical artery. This one, all right? This is the obliterated umbilical artery. And all these structures are below this, which is coming from the internal iliac artery, as well as the obturator artery is also coming from the internal iliac artery, right? Now you can see in the upper part, ureter process at the bifurcation of the common iliac vessels, that is into external iliac and internal iliac. This is external iliac and these are the internal iliac, right? So common iliac vessels, artery and vein, where it is bifurcating, that part is overlapped by, that is superficial, ureter is superficial to this. Got my point? And in the lower part, this is vas deferens or the round ligament of uterus that is overlapping all this structure. This is the relation of obturator nerve. Got my point? As well as the relation of the vas deferens or round ligament of uterus. I can draw another figure also. All right, I can draw another figure also to show you the entire course of the vas deferens, but I don't have that much of time. I will draw it if anything, if any scope occurs. All right. Now, one thing is, the testis develops. Let me wipe it off. As you know, that the mesonephros, that is the mesonephric reed, is a part of the intermediate cell mesoderm. Never forget that our genitourinary system developed from the intermediate cell mass. It develops from intermediate cell mass. All right. So, as you can see, this is the developing mesonephric reed. All right. And by 50th, we can see there are the mesonephric tubules are also there. All right. And I am not talking about pronephros. Remember, pronephros, that is the mesonephric reed extending at the cervical region. All right. I am not talking about pronephros. All right. Because all parts of the pronephros disappear. Only its tubule is attached to the mesonephric development. Now, medial to this, there is a genital reed that occupies the medial two-thirds of the mesonephric reed. All right. And as you know, that the primitive germ cell migrates along the dorsal wall of this mesoderm. All right. Right. I have told you that if this primitive cell enters into the cortex of the developing genital reed, it is an ovary. It is going to develop an ovary. And if it is reaches the medulla, it is going to develop a testis. Right? So testicular tissue is much more core tissue, as I have described earlier. Got my point? Now, after this formation, what we see, I need to draw another figure. All right. I don't know you will understand or not. This much is enough for mesonephric reed and medial, that is the genital reed. All right. Let me draw another figure quickly. What is the time now? No. I will draw later on. All right. I need to talk something about the descent of testis, undescended testis, ectopic testis, like this. All right. Remember, you have seen this genital reed and this mesonephric reed. Remember, from the posterior abdominal wall, there is a fold. All right. This is called the mesentery of the mesonephron. All right. Now, from this, its lateral aspect, a fold descends downward and joins medially, forming a structure which is known as the genital cord. Right. And more laterally, from there, a peritoneal fold comes down. And with this, the mesodermal tissue incorporated into it gives rise to the gubernaculum of testis. This is genital reed, this is mesonephric reed. This is by one mesentery. Right? From its lateral part, there is a fold that is uniting in the midline. That is the genital cord. And more lateral to it, there is another fold is coming down. Incorporated mesoderm in it gives rise to the gubernaculum of testis or round ligament of uterus. The upper connection towards this is known as the suspensory ligament of ovary or test or uterus. All right. and the lower part is the gubernaculum testis. I will draw. You just remember the words only. Alright. This gubernaculum testis, gubernaculum or the round ligament, passes through an inguinal fold. Passes through an inguinal fold and goes to be attached with the anterior abdominal wall, part of lower part of anterior abdominal part, which is destined to form the either the labia majora or the scrotal wall. Alright, this is going towards that. So, as I have drawn the peritoneal cavity, this is the retroperitoneally developing testis. Alright, and a process comes out along with the descending testis. This is called process of vaginalis. The whole part when remains, it is congenital hydrocele, right? And usually only the distal part that overlaps covers the testis that remains, which is known as the distal remnant part of this process of vaginalis is called the tunica vaginalis, right? Where the hydrocele develops. Where the hydrocele develops, that is the outer serous sac of the testis, right? Which is definitely a parietal layer and the visceral layer, right? And when this is coming down, the lower pole of the testis, is attached to what? Attached to the gubernaculum, right? As if the gubernaculum is pulling down the testis towards the scrotal sac. What my point? Gubernaculum is called a hem, maji, right? A rudder that is guiding the descent of the testis. Along with there are other factors also, that is much more space is wasted by the development of different organs, especially the liver, spleen, alright, the gut. So there is very little space for the testis. Number one. Number two is abdominal temperature, internal temperature of abdomen is increasing. Testis has to rescue its cell generation procedure. So it needs at least 2 to 4 degrees centigrade lower temperature. That's why the testis is descending. There are many other theories, hormonal factors, etc. etc. The main anatomical factors is the gubernaculum of testis. The main band of testis, remember there are at least 5 bands of testis which are known as tails of Lockwood, L-O-C-K, wood, W-O-O-D, tails of Lockwood, right? Number one, the main tail goes to the base of the scrotum, alright. Then another is towards the pubic tubercle, so it is the pubic tail. Another is towards the deep perineal pouch, that is the perineal tail, right? One might go to the anterior superior iliac spine, one may go to the saphenous opening. What's my point? These are the tails of Lockwood, according to which, if the main band is not that much powerful or potential, or it gets degenerated, the testis will deviate, alright, towards any other side. What's my point? That is either lateral to inguinal ligament or medial to inguinal ligament at the saphenous opening, that is near the femoral opening of the saphenous vein and the femoral vein, alright, or towards the perineal pouch, in perineal time. All these diverted positions are called ectopic testis. All these positions are ectopic testis. And if it fails to descend at all, it is called undescended testis. Now the thing is, how if a mother comes with, suppose 6 to 7 years old, with a 5 to 7 years old child, I think the left or right or both the scrotum are empty, right? There is no testis in it. Now what will you do? The thing is that, you will first try to understand. You will put your little finger into the scrotal sac and come up to the superficial inguinal ring, and from the upper palpation of the superficial inguinal ring close to the pubic tubercle and pubic crest, alright, you will try to find anything swelling is there or not, because most often the retractile testis, that is the sensitive male, when you know that is the trimesteric reflex, very small stimuli at the medial side of the upper part of thigh, that gives rise to trimesteric muscle contraction to the genito, that is the trimesteric branch of genitofemoral nerve, and there is sensory to the femoral branch of genitofemoral nerve, that is L1, alright. So that can contract the trimesteric muscle, and this can go to the superficial inguinal ring as well as in the superficial inguinal pouch. What is superficial inguinal pouch? It is the space between the fossa of Scarpa and the external oblique aponeurosis lateral to the pubic tubercle. Right? So there can be the testis. So nothing to worry about. But if it is found in the inguinal canal, as you can see, that is at the 10th month it reaches by birth. 10th month it reaches at the superficial inguinal ring. All right. By 9th it is in the scrotum. By 9th it is in the superficial inguinal ring. By 8th month it is in the inguinal canal. Right. By 7th it is in the deep ring. All right. This is the descent of the testis. Normal descent of the testis. If it is not found there, what will you do? Remember, undescended testis causes two important complications. By 6 years, the spermatogenesis procedure is on, will become on, full-fledged. After 6 years, this will not be of full-fledged something. Alright, so testis must be placed within the sac at least by 6 years. After 6 years, the spermatogenic cells will disappear, degenerate. Alright, so we have to do operation, that is orchidopexy. Alright, orchidopexy. Either in one stage operation or in two-stage operation. Right? Orchidopexy operation. And there are other operations also, that is there is Brown operation, kidney thorax operation, Omberden operation. You need not to mention those. You can write just Dennis Brown operation, Omberden's operation, kidney thorax operation. You can mention this now. You need not to write anything about this. You can just tell the operation should be done by 6 months. Otherwise, the testicular potency will be, spermatogenetic potency will be lost, and it can be done either in one stage operation or the two-stage operation. Otherwise, this undescended testis will give rise to a frequently known tumor, that is the seminoma. Seminoma. That is the seminoma. Today I didn't draw the appendix of testis or epididymis. Right? I didn't draw it. Alright. But you can remember in the earlier diagram I drew the appendix of testis, appendix of epididymis. Alright. Appendix of testis is a, when there is a cyst formation, it is a sessile cyst, hydatid cyst of Morgagni. It is called sessile hydatid cyst of Morgagni for testis. There is sessile means there is no stop. Alright. And for the epididymis, this is known as pedunculated cyst of Morgagni. Right. And when somebody will describe the embryology of the testis, you will remember that most of the mesonephros get degenerated. Alright. Only part of it remains patent, which is known as the paradydymis or Garland's body. Gerald or Garland's body. G-E or A-R-A-L-D-E apostrophe S. That is paradydymis. Right. Now, two things needed to be explained. Number one is phimosis and paraphimosis, and the varicocele. Varicocele, I think you know varicocele. Let me talk about a little of the phimosis and paraphimosis. There is a curiosity in adult women, in adolescent girls, alright, to try to see the newborn baby's penile part. Alright, this is interesting. Alright, male are not that much interested in seeing the little baby tubules. Alright, sometimes what happens, as you know, this is the penis. You know the cross structure of penis? No, do not know. There are two muscle columns which are known as the corpora cavernosa. Alright, and in the central part, come. Remember the position of penis. What we expect? That is, this will be the ventral surface and this will be the dorsal surface. No, that is not. Imagine this straightened part, then this is the ventral surface, the anterior part is the dorsal surface, right? And so this is the, what is this? This is not the ventral surface. Normally this is like this, all right, but this is not the ventral surface. You make it straight, right? This is the ventral surface and what is anterior now is actually the dorsal surface, right? So in the lower part, all right, that is in the actual ventral surface. All right, there is, you can feel when there is a muscle column that is known as the corpus cavernosum, through which the ureter passes to the tip of the glans penis. Right, there are two columns, solid column of muscle that is known as the corpora cavernosum. Which one is cavernosum and which one is spongiosum? Spongiosum creates the space for the urethra. Right, cavernosum gives it shape, and all around there is a fibroelastic covering that is known as the Bach's fascia. This much is enough. All right. Now remember, this spongiosum dilates anteriorly, giving rise to the glans penis. And the skin, right, and the constriction beyond the glans penis is called the corona glandis, right, where the foreskin cannot be retracted beyond this corona glandis is known as phimosis. The condition where the foreskin cannot be retracted beyond this corona grandis. All right. During birth, there is a very tiny aperture at the apex of the foreskin. All right. And if this aperture is not there, that is, if there is a congenital phimosis, this part will balloon out. This foreskin will balloon out at the first attempt of micturition. If this is not complained of, then it is not a congenital phimosis. Done? If at the first attempt of micturition there is ballooning of the foreskin, this is congenital phimosis. If anything happens later on, this is not congenital phimosis. Got my point? So, if you cannot retract this beyond this corona glandis, this is the glandis, this is the glans penis, and this is the corona glandis. So, definition of phimosis is when the foreskin cannot be retracted beyond the corona glandis. This is phimosis. All right, this can be congenital, this can be acquired. Most of the congenital cases are also due to either dermatitis, balanitis, balanoposthitis. Balanitis means inflammation or infection of the glans penis. Posthitis means that is the dermatitis or infection of the prepucial skin. Right? Balanitis, balanoposthitis, and combination is the balanoposthitis. Got my point? And sometimes it can happen due to trauma, whether there is adhesion between the glans and the prepucial skin. Alright, what we need to know is that if we forcefully try to retract the foreskin, alright, beyond the glans penis, what happens? There is a secondary constriction around the glans penis. This is called paraphimosis due to inadvertent pull of this foreskin. Got my point? This is called paraphimosis. In case of phimosis, the operation we do, actually we don't do. We don't practice circumcision. Alright, we don't practice. I don't even like the circumcision operation. I have seen in BC Rai Children's Hospital. So I didn't like it. Why I didn't like it? You see, when we cut this, you know, at the back of the at the back, if I draw this from the back aspect, all right, you will find there is a frenulum. You know the term frenulum? You know the term frenulum? Frenulum is a tug of mucoid tissue, alright, soft tissue that keeps our tongue in position, alright, and controls it. It is the rein of the tongue. This is the frenulum, alright. There is the frenulum lingui and this is the frenulum peni, phallus, alright. This frenulum, so what we need to do, we have to do a incision like this under GA, keeping this part intact, not up to this part, keeping this frenulum intact, alright. So we make an incision like this, alright, where the upper part is above, the lower part is enclosing. এরকম ঠিক আছে এইখানটা frenulum that should be kept intact, alright. When you cut this skin and the prepuce, what happens? There is profuse bleeding. You will not be able to tolerate. Oh, a little baby is bleeding this much. Because we cannot put any adrenaline local vasoconstrictor injection because this part is very much sensitive, and you cannot do cauterization also. Cauterization stop the bleeding very early. But if it is get heated, alright, the tissue will be degenerated, disturbed. So we do not use even the cautery. So diathermy is not used and any vasoconstrictor is not used. Got my point? So you have to do it either through small mosquito forceps and rapid suturing. You need to do a rapid suturing. The prepuce, alright, it is the prepuce, the inner layer, like that lip. This is the foreskin, right, and this is the prepuce. Alright, when this prepusal sac is intact, this is called congenital phimosis, and when the prepusal sac is open, right, this is not congenital. Got my point? This foreskin we cut up to this, and then we rapidly interrupted suture, not a continuous suture. With catgut, 20 catgut or 30 catgut, we rapidly suture this layer. Otherwise there will be profuse bleeding and 2 persons cannot handle. 2 surgeons cannot do the job because it is very little space. Alright, you put interrupted suture and close it, then you put supportive bandage, alright, and then what you have to do to prevent any straightening or erection of the penis. Whenever there is micturition tendency, usually the penile part reflexively straightens or erect. You have to prevent by anticholinergic medicine which is known as tropan. You will read it. Tropan 5 milligram we give at least 3 days for this little baby so that it is not erected. Alright, this is phimosis, and in case of paraphimosis, from the dorsal part we a part of the skin is excised, that is called treatment for paraphimosis. Another thing is the hydrocele. What is hydrocele? As you know, there is a dilatation of the testicular venous plexus as well as there is a pampiniform plexus as well as the cremasteric vein. Cremasteric veins drains into the inferior epigastric vein. Alright, and testicular vein on the right side, it enters into the inferior vena cava in an acute angle. Alright, but in case of left side, it enters the inferior vena cava in a right angle. Alright, this venous system is mostly devoid of valve. This venous system is mostly devoid of valve, especially at the termination, mostly on the left side. Right? And what is important, the left kidney is higher up, left testis is low down. Left kidney is higher up, left testis is low down. So this pathway is a longer, and moreover, this is compressed over the psoas major muscle by loaded colon. This is compressed by the loaded colon over the psoas major muscle. So there is obstruction, and another thing, there is sometimes testicular artery which may again compress over this draining part of the arch testicular vein. Arch testicular vein artery can again compress over this draining side. All this together with a physiological factor, that is where the left renal vein drain, left testicular vein drain, there is opening up of veins of the suprarenal gland, which is carrying adrenergic substances that can constrict this venous drainage site. All this predisposes to left-sided varicocele. These are the causes for predilection of left-sided varicocele. This comes very often. All right. And what do you do? What do you do? What do you do? You can open up the worm-like bag of worm like the testis. Who is the person that suffers from varicocele? Remember, tall, thin and viscerototic person. Tall, thin and viscerototic person suffers from varicocele. Nor a stout, well-built person suffers from varicocele. Alright, he will complain, I feel there is an enlargement of the testis and there are something that makes me understand there are multiple testes. Bag of worms feeling. Alright, there is usually no pain and this condition is idiopathic. Nobody knows what is the cause. The thing is that when the temperature increases, there is hampering in the spermatogenesis procedure and there will be oligospermia. You will find adult person coming with a semen analysis report with oligospermia, and when you will examine the case, you will find that the patient is having left-sided varicocele. This is the most common presentation nowadays. Alright, due to subfertility, the patient is presenting to your surgical OPD or chamber because of subfertility. Alright, I do not take to explain the operation right now. I will talk to you later on. Alright, thank you all.